Good afternoon, everyone. I hope you are all keeping safe and well. My name is Meaghan Stovel McKnight, and I'm the Chief Operating Officer of the Princess Margaret Cancer Foundation. Thank you so much for joining us today. We are truly in an extraordinary time for all Canadians, and in particular for cancer patients and their families. The reality is that cancer did not stop because of COVID, so neither can we. Despite all of the challenges of the pandemic, our world-leading cancer researchers and clinicians are continuing to define the future of cancer care. They are transforming, reimagining, and redesigning the patient experience. They are embracing digital connectivity, emphasizing comfort and access for all patients, and innovating it to provide care beyond the walls of the cancer center, all while delivering world-leading cancer care at our truly global cancer program. All of these ideas will be explored in depth over the next few months through our newest 4-part webinar series, High Touch, High Tech. Throughout this series, we will dive deeper into how we're reshaping the future of neurosurgery, how we're paving the way for STEM leadership in both this generation and the next, how we're leveraging big data to fuel the future of cancer discovery and care, and how we are centering all of this work around an exceptional, inclusive patient experience. And we will explore all of these ideas by giving you the opportunity to hear from the clinicians, scientists, and staff behind them. It's going to be a very exciting few sessions. Now, kicking off the series today, we're beginning with a deep dive into our unique Cancer Experience program. We will explore the challenges and opportunities created by this program, which is designed to support the interconnected well-being of patients, families, staff, and trainees throughout the trajectory of cancer care. World-leading cancer research and exceptional patient care is at the heart of what we do with the Princess Margaret. But we all know that it is the patient and family experience that can make all the difference in someone's cancer journey. Now, before I introduce our guest today, a reminder that we will have time for an interactive question and answer, and we would love to hear from you. And you can submit questions throughout the session using Slido. The link can be found in the session description below. It's my pleasure to introduce Dr. Gary Rodin, the inaugural director of the UHN Cancer Experience Program. He is a professor of psychiatry at the University of Toronto and holds a University of Toronto and University Health Network chair in psychosocial oncology and palliative care. He led the establishment of the Department of Supportive Care at Princess Margaret and the U of T Global Institute of Psychosocial, Palliative, and End-of-Life Care, which he now directs. He also leads an internationally recognized clinical and research program at the Princess Margaret, focused on the development and evaluation of new interventions to improve the psychological well-being and quality of life for patients with cancer and their families. Dr. Rodin has published 3 books and almost 300 publications in these areas and has been recognized for his global efforts to improve access to psychosocial and palliative interventions for patients and families facing advanced disease. Welcome, Dr. Rodin.
Hi, Meaghan. Glad to be here.
We are also very fortunate to bring a unique perspective to today's discussion with the participation of a former patient of Dr. Rodin's, Jennifer Bell. Jennifer's journey with the Princess Margaret began in January of 2016, when she was diagnosed with multiple myeloma, for which she received 2 stem cell transplants. Through the course of her treatment, which is ongoing, mental health and emotional well-being have been critical aspects of her journey. Welcome, Jennifer, and thank you so much for being with us today.
Hi, it's really nice to be here as well.
Now, before we begin, I would really like to ask, how are you both doing? How are you and your family doing amidst the craziness of this pandemic? Jennifer, I'll start with you.
Well, I'm doing really well. I'm learning how to spend a lot of time on my own, doing lots of alone time things, but it's good. It's good. I'm well. We've only had 1 person in my extended family with COVID, and he's recovered. So we're
that's
pretty
wonderful.
lucky that way.
That's wonderful to hear. And how about you, Gary? How are you doing?
I'm doing fine. We're all doing well, trying to find ways to live creatively in these times. But it is a difficult time, Meaghan, as you know, for many people, including people with cancer. And so we're also looking for new ways to support patients and families as they go through a difficult time that's made a little bit more difficult by COVID.
Absolutely, absolutely. All right, now, Dr. Rodin, let's set the stage for the conversation. You've recently transitioned from the Director of Palliative and Supportive Care to our new role as Director of Cancer Experience. Can you share with us a little bit about this role and what's your vision for this program?
Well, the vision for the program is something that I've been focused on for a lot of my career in this work. It's trying to improve, as you said, the experience for patients and families with cancer. And you might ask, what's new about that? Well, actually, hospitals, cancer hospitals, tend to be highly focused on the cancer, understandably, on the disease. And hospitals like and cancer centers like Princess Margaret do very well at that. I think we have world-leading treatment for cancer of all kinds: radiotherapy, chemotherapy, surgery. We've done a lot, Meaghan, to improve supportive care in this area, but I don't think we do nearly as well as we can do in the area of patient experience. What about the well-being of patients and families as they go through what is a confusing, frightening, and difficult experience? So it's trying to improve the quality of life and the experience for patients and families, and at the same time trying to support patients and staff and trainees who are going through it, knowing that we're all kind of interconnected. We're all kind of in this together. That's the sort of overall vision, and to look for novel ways to do that.
Oh, it's such exciting and important work. So Jennifer, I'm going to turn it over to you. At the center of all of this work is the patient. So maybe you could tell us a little bit about an overview of your cancer experience. When were you first diagnosed, and tell us about what happened along the way?
Well, I was first diagnosed in September of 2015, and I consider myself extremely well-read in anything medical, and I knew a lot about cancer. But the problem was I had never heard of the type of cancer that I was diagnosed with. And so it made me absolutely frantic with worry. So it was a really shocking diagnosis. And from about that point on, I was frozen. And the most difficult thing about my early diagnosis was there was nowhere to turn for advice or help. My family doctor, I was his first cancer patient. He didn't know really who to call. You know, the Canadian Cancer Society, maybe. It wasn't easy to say, who do I call? Hey, I heard PMH was a great. Is there anyone I can call there? We didn't know who to call or what to do, and we made a lot of really bad decisions early on, because the theory is if you don't get treatment right away, you're going to die. I know that's not really the truth, but that's what a cancer patient feels like. Imminent death is just around the corner. So it was hard. The beginning part was really, really hard. I wish there had been a place to turn to.
Well, that, thank you for sharing that experience with us, Jennifer. This is exactly, I think, the kind of information that Gary and his team need to hear so that we can create better transitions, especially in those early stages of the cancer experience. Now, Dr. Rodin, today's theme is focused on the human touch in cancer care. And how do we make that a really human experience, especially listening to the words Jennifer just shared. So what does the human touch in cancer care mean to you? And how does this define your philosophy around cancer experience?
Well, Meaghan, there's been huge advances in cancer treatment, in the technology and the biology of cancer treatment. And we've extended survival in many cases. We've made enormous advances. But as medicine has got more technologized and specialized, I think we've lost track of some of the things that Jennifer was talking about, is what it's like for patients and families. As Jennifer described, what a confusing and frightening experience it is, and people don't know where to turn. There's those people who don't know how to get access to the cancer center, even though we have a publicly funded system. And then once in the cancer center, they don't know who to ask or where to turn. So one of the things we'd like to do is make that process much easier to navigate. I was talking to Jennifer earlier, and the metaphor I used was mountain climbing. If you were going to go mountain climbing, you would get prepared for how to do that. And we haven't done that well enough for cancer patients. It's no less difficult than mountain climbing, but we need to make routine how to navigate the system, how to enter the system, how to get information that you need, how to get support that you need, how to deal with the fears that you need, how to make that you have, how to make treatment decisions along the way. We have to make this part of routine cancer care, just as we do that with all the other technological and medical things we do in cancer care.
Now, Gary, I'm aware as you in your cancer experience program, you've developed a framework, an acronym, and there's always some great acronyms in the medical world. Sunday,
Yes.
like an ice cream sundae,
Yes.
and I think you just talked about navigation as the end, but it covers supportive communication, navigation, diversity, inclusion, equity, and access, ambience, and engagement. Why are these the core elements that you're focusing on?
Well, these are the things we found that are most problematic for cancer patients, and also that we do less well as a medical community. Medical training, undergraduate, postgraduate medical training is much more focused on biology and technology and much less focused on, for example, how to communicate with patients. We kind of assume that doctors know how to communicate bad news to a patient, know how to deal with difficult emotions, but in fact, they need training. They need training just as they do in all other aspects of medicine. So this is the kind of thing we want to make routine. And Meaghan, going back to the framework of the foundation of high tech, high touch, we want to make a lot of use of technology in order to humanize the experience. We've learned a lot by necessity, I think, in COVID about how to do that. And so when we talk about navigation and information, we want to talk about communication, even as we're doing today. We want to make as much use of technology as we can to humanize the experience and to make it less frightening for patients as they go through the journey.
I guess one of the most important things, if we're really going to build out a patient experience, is understanding, who our patients are. So can you speak a little more specifically around the work in diversity, inclusion, and equity and access? And how is this impacting patient-centered care?
Well, Canadians, I think, justifiably and reasonably want to think of themselves as open-minded people who are accepting of everyone, and I think we are. But we don't do well enough in terms of allowing people access to treatment resources. So first is who gets into the cancer center. We know that people who don't speak English, people from marginalized groups, people that don't have a primary care physician, have difficulty getting timely access to the cancer center. And when they get into the cancer center, we don't pay enough attention to language diversity, to differences in cultures. Toronto, as you know, is one of the most multicultural cities in the world, and we need to do a lot more about how to provide culturally sensitive services, how to provide services in different language, and how to pay attention to different age groups. For example, we know that young people with cancer often feel strange in a cancer center because cancer more often occurs in older people. So we need to think about how to support and how to communicate with younger patients, how to differently communicate with older patients and patients who are frail and vulnerable, patients with mental illness and psychiatric illness. We need to identify all of these people with special needs on entry to the cancer center, and then we need to make available to them a whole range of tailored and specialized services. Some of them are traditional services in supportive care, and we're also making use of non-traditional approaches. We now are in discussion with the Toronto Symphony. How can we bring musicians into the cancer center? How can we bring art, including culturally diverse art, in the cancer center? What can we do to improve the ambience of the clinics, make it less frightening? And I mentioned about communication. We're now hoping to develop an online digital tool, a communication skills training tool, so that all doctors and all nurses using videotaped interviews and interactive online platforms, that all doctors and all nurses get proper training in how to communicate with patients, how to break bad news, how to support people who are frightened and anxious. These are some of the developments. We have a research structure so that we're evaluating all of these things. And the idea is to make them not available just to people at Princess Margaret, but actually in the world.
It's fascinating work and so exciting. Jennifer, I'm going to turn it back to you and let's talk about your experience specifically. What did you find helpful in the cancer clinics and in your relationships with your cancer treatment team? And what are your thoughts on how this might be improved?
Well, my clinic was called the hematology clinic because myeloma is a blood marrow cancer. And I was extremely lucky to find a doctor there that allowed me to email him any worries or questions I had at any time. And that was without a doubt the most important asset that clinic gave me, because there were so many questions that I had and so many worries with the amount of drugs I was given and all of that. So that really helped a lot. That not only did it help me, it helped my family, because if they had a question or a worry, they emailed as well. We didn't overuse it. It was just a great tool. And that was the best thing that happened in the clinic.
Oh, that's fantastic.
The
And so important.
problem that wasn't that good. The problem that wasn't that good that I found the most difficult for me to navigate was that a lot of the doctors and nurses within the clinic weren't that proactive with information about the drugs and the reactions that I was going to go through on these drugs. And it's very personal. I know it's difficult to discuss and to find out about, but that was difficult, really, really difficult.
Yeah, well, that's very helpful feedback, and that kind of need for proactive patient education seems like that's some really helpful feedback I think Gary and his team can use as they build out this program. Mm-hmm. Thank you for that.
Okay.
Dr. Rodin, Princess Margaret's goals include increasing comfort and confidence and reimagining our patients' experience to enhance their quality of life. That's where we want to just see where we can go with this. And one real specific approach is being really patient-centered in care. Can you describe some of the elements of what patient-centered care means? You're on mute. I think you're still on mute, Gary. Thank you.
Sorry about it. Some people might find it strange that we're talking about patient-centered care because they would say, what's the alternative? Isn't all care patient-centered care? And of course it should be, but so much of medicine is focused on the disease, on treatment of the disease, on the technology, on the MRIs, on the blood tests, and this is extremely important. Anyone who has cancer wants the very best treatment for their cancer. But I think we've lost sight of how important is the patient experience. And some of it is very simple. What Jennifer is talking about is preparing patients adequately. If you're going to go through chemotherapy or radiotherapy or surgery, to know in advance what side effects you might expect, what the treatment involves, and how to prepare yourself for treatment. Jennifer's, I think, in the past talked about nutrition. Do we pay enough attention to very practical things like that? So at every stage of the journey, trying to put ourselves in the shoes of the patient and the family and to try to support them through the process. And the family, by the way, Meaghan, is a very big part of it. That's another thing we haven't paid enough attention to, that behind every patient is a family, often who are supportive, often who are frightening. In fact, you were at our symposium the other day, and we had a colleague from Rwanda who was speaking, a surgeon and palliative care physician. He had a very nice way of putting it. He said, when you are well, you belong to yourself. He said, when you're sick, you belong to your family. And the families are the major support for people with cancer. And we don't do enough, Meaghan, routinely to support families. We know there's enormous burden. There's financial burden. There's the burden of care. There's all the other problems and issues you had in your life before the cancer. We want people, we put more and more responsibility onto caregivers. We now need to do more to support them, to support the patients.
So how do we make this standard? How do we make patient-centered care the standard way we deliver care?
Well, that's part of the purpose of the program, that everyone agrees, or most people agree, that this is extremely important. But we haven't taken a systematic approach to it so that this happens routinely, automatically, not just when someone seeks it out, but it's part of routine care. So it takes understanding how important this is, and it takes some support. We haven't had the resources to do this. We could say that's the bad news, if we want to say it that way, that we need more resources. The good news is that it's actually the most efficient way to expend resources, in the sense that this is much less expensive than any other aspect of cancer care, that we know that the drugs have become extremely expensive, radiotherapy, surgery, these are all very costly, these interventions. Supportive care is the least expensive aspect of cancer care, and yet it's been under-resourced. So Cancer Experience is an attempt to make this, to bring resources to it and to make it a routine part of cancer care. Sometimes with simple interventions, sometimes with more complex ones, and whenever we can, making use of technology so that it can be available remotely.
That definitely sounds like a program with a great return on investment, that's for sure. Jennifer, I'm going to turn it back to you. Dr. Rodin spoke about navigation and the complexity of the processes. Cancer treatment can be a very complex process with lots of treatments and lots of decisions. So what was that situation like for you?
Well, first of all, it was not an easy path, mainly because the drugs made me, not only me, most likely every cancer patient, they make you crazy. They make you lose your brain. There's huge brain fog. I'm no longer in charge of my mental ability, and my family is actually in charge. And it took a long time for me and my family to understand that I wasn't just sad because I got cancer, which is what they thought at the beginning. I was sad and depressed and out of it because I was on so many drugs. Now that the drugs were good to be on because they were going to make me better, but they make you crazy. So that was a really hard thing to do. It took me 6 months of treatment at PMH before I realized that there was a psychosocial department that I could get help from. And that was only because my daughter emailed my oncologist, who then emailed Dr. Rodin, who said, there's someone in crisis who needs to talk to you. So it took a long time for me to know that. We didn't know that PMH offered this service.
Yeah. So, I mean, it sounds like obviously better resources to let you know what resources are available early would have been helpful.
Once I found out about it, it was like, wow, this is going to be a lifesaver for me. And it turned into being a lifesaver for me. It's made a huge difference that I'm able to talk with Dr. Rodin and work through fears and of what happens when you have cancer.
Yeah, this need to really make sure the whole person is cared for,
right?
Their mind, their body, their spirit, and making sure all those pieces are part of the journey.
That's right. It's difficult to talk to your family about worries about dying because people don't like to talk about that. They go, oh no, you'll be fine. You'll be fine. Why don't you just be positive? And you're going, yeah, no, I really want to just talk it through with someone. And that's where it's so important to have someone like Dr. Rodin and people in psychosocial to talk it through. You have to be able to be honest about your feelings.
Absolutely, absolutely. Thank you, Jennifer.
Okay.
Now, Dr. Rodin, your approach emphasizes another important aspect that sometimes is overlooked, and that's the health and well-being of our care teams and clinicians who are working every day with patients and their families. And I think this is especially topical given the result and the stresses of the ongoing pandemic and the concerns around burnout among frontline caregivers. So how are you addressing health and well-being for care teams at Princess Margaret? And what difference do you believe that will make in the patient experience?
We've learned a lot about it, Meaghan, I think through COVID. I think it's always been important, but I think all of the concerns about the patients and the social isolation and the fears of infection and the hours people who were working just highlighted how much stress there was on staff. And we need to support them for their own well-being. But as you said, their well-being is very closely linked to the well-being of patients and families, so that we're helping everyone when we help one part of the system. We also haven't done that very routinely or systematically. So we're now developing team-based approaches and individual approaches to support staff who are going through difficult moments. We're developing online interventions for wellness for staff. Again, to have all this be part of routine care. There's a lot of evidence that burnout is very common in cancer caregivers and doctors and nurses. We need to address it in a proactive way. And the trainees too. We have residents and students who are involved with patients experiencing the similar distress, and we have to help them as well. Our communication tool, funnily enough, we think will help that too, because part of the stress for caregivers is the emotional difficulty of communicating bad news to patients in difficult situations. It's hard for the patients, but it's hard for the caregivers. We need to help them manage their own emotions better as they communicate with patients who, as Jennifer described, can be frightened, anxious, depressed, going through very difficult times. So that I think what we said before is that being proactive is really the key. We don't wait until there's a casualty or a problem. We try to do this in a proactive way, which is the way medicine is moving towards prevention. We don't only wait until there's a problem. We try to prevent health problems.
And I think Jennifer was talking about that earlier with patient education and not the need to just educate on side effects or resources once the patient really needs them or dealing with side effects, but but in anticipation, so they're educated as they go down that pathway. And same thing with caregivers. Yeah. We of course, as you mentioned earlier, there's a very big research component of the patient experience program. We have a very exciting program that's been underway this year at Princess Margaret, an internal grant program called Grand Challenges, with an idea of really activating next level thinking across a lot of the areas of the research work and clinical work at Princess Margaret. And we're very excited that we have one this year focused on cancer experience, calling for new ideas, which will support innovative and high impact projects across the spectrum of care. What does it mean, Dr. Rodin, to have cancer experience as a focus of one of the calls for these new projects?
Well, it's very interesting, because often when people think about research, they think about laboratories or basic science labs. They don't think about the things that we're talking about as research, but in fact, of course, these things are all benefit from novel approaches, and they benefit from evidence about them. So we put out a call, thanks to the donor support in the foundation, we were able to mount this grand challenge. We didn't know how much interest there would be, but I can tell you there were 27 team-based applications. We had 27 teams. Each team involves 5, 7, or sometimes more interdisciplinary teams. This includes oncologists and psychologists and technology people, all coming together with novel approaches. And they ran the competition is in play, but the grants applications are ranging from everything. How do we support cultural and language diversity, for example, from the beginning? Very practical things that when patients are going through difficult experiences, for example, in radiation therapy, how do we make this less frightening and more comfortable for them so that they're not immobilized in a frightening way while they go through a procedure like that? Some of them are the kind of team-based interventions to support staff. Some of them are psychological or social interventions. Some of them are technology-based. They're almost every aspect of the whole cancer experience. Some of them involve music as well. How can we use music at all stages of cancer? So it's quite exciting to see these new ideas generated and to see these teams coming together, having cancer doctors and mental health professionals and technology people, the whole range of disciplines to think about how can we improve the experience of cancer for cancer patients. So I'm just delighted, and it's a hugely wonderful way to launch this program. So thanks to the foundation for the support of that.
Well, thank you to our donors for making it possible. And I know that we're excited with 27 projects. I know only one will win the grant, but we plan to do this for many years, and look forward to working on raising all those projects, bringing those forward. So looking forward, Dr. Rodin, what does success look like at the end of 1 year, 3 years for this program? How will the patient, family, and clinician experience look different?
Well, the first thing I would say is that success about this will be that we're not simply talking about these things. Success will be that we actually change things. So in each of the stages that we're talking about, can we improve access to the cancer center so that the diversity of patients in the cancer center reflects the diversity of the city? How can we have better information, education, and navigation so that we don't have the kind of experience Jennifer talked about when you enter the cancer center and don't know where to turn? That we have patients getting better routine access to existing interventions, that we have novel interventions and novel approaches, that we reach a whole variety of age groups and cultural groups, that we have a communication skills training program that's online, that is ready to become a state-of-the-art for the world, and that we have a caregiver program. We want a more systematic program that supports caregivers through the course of the whole cancer trajectory. Those are just some of those, but those would be some of the short-term goals, Meaghan, that would be part of what we're calling patient-centered care, high-tech, high-touch, or as we referred to in our symposium the other day, linking biomedicine with the soul of medicine. We want to do both of those equally well.
Amazing. You've mentioned the symposium a couple of times, Dr. Rodin. Would you share with our viewers today what this symposium was about? What was the scope of it? How many countries were represented? I think they would be really interested to know this global partnership that was taking place, led out of Princess Margaret this week.
This was a symposium. It actually came out of a meeting, a casual, accidental meeting I had with Richard Sullivan, who is the head of the Institute of Cancer Policy at King's College in London. And we were at a meeting in Africa, in Maputo, Mozambique, when we began to talk about the fact that there wasn't enough attention to these kind of issues and also to the cultural phenomenon, to the differences in culture. Because when we talk about support, it isn't the same that's needed for everyone. depending on their age, depending on their gender, depending on their cultural background. And often meetings in palliative care are much more focused on the not only medical part of it. So we began to think in this way. And from this, we brought in other groups, the European Palliative Care Research Center, the Dalai Lama School of Public Health, multiple other groups. And we had a symposium that took place over 3 successive weeks. We had 600 people in the field of palliative care from all areas register in the symposium from 60 different countries. Our speakers included a health economist from Duke University. They included a cultural anthropologist from MIT. They included palliative care doctors and people from all areas. So thinking in a broader, creative way about palliative care, about cancer care and supportive care than would ever take place at an ordinary medical conference. So it was quite exciting. And we had the editor of the Lancet Journal, which is the premier medical journal in the world, who came to all of our sessions over these 3 weeks and wants to be a partner with us in taking this forward. So I think lots of exciting things will come from that too. And it is all about the patient experience, actually.
Yeah, what an incredible environment for such exciting ideas of discovery to come from. That's fascinating. That's fascinating. Jennifer, I've got another question for you.
Okay.
Dr. Rodin's talk about the launch of this new cancer experience program. What are the top 1-2 things that you think are really important for him to think about as he moves this forward with the team?
Well, I'm pretty excited about what he was just talking about. The symposium and all that sounded like so exciting. For me, the biggest impact was my ability to email my doctors. The second most important thing that would have helped me through and still help me would be knowing about what's offered in the hospital or through the hospital for mental health and cancer health. Where do I find it? Who do I talk to? Do you have any podcasts? Is anyone curating anything that I can learn about nutrition? Who's doing what about, where is it? Where is it? Where's the sign for it when I walk in the door? Right. And I must say that the new renovations are pretty amazing. Since my first 5 years of treatment at Princess Margaret were sort of not in Dourville. It was really depressing there. But now it's so sort of uplifting and beautiful. I still want to see the signs for, so where's psychosocial, where are the meetings, where's the place? Where do I go? Who do I talk to?
Yeah, it sounds, a lot of that, the communication is at the heart of this.
Right.
And, proactive communication.
Yeah.
Yeah.
That would be it.
Wonderful, wonderful. Well, I'm gonna pass it over to you, Dr. Rodin, for one more question before we open it up to our viewers. Looking ahead, Dr. Rodin, I understand you also have your own book coming out in March with Oxford University Press. Can you tell us all about it?
Well, cancer's not just one thing. There's many types of cancer, and there's problems at different stages of the disease. But we've taken an interest in people living with an incurable disease. So they may be going through cancer treatment, they're getting chemotherapy or other cancer treatments, and they're also trying to live their lives. This can be a very challenging situation, and we also haven't been proactive about it. So together with my colleague, Sarah Hales, psychiatrist in supportive care, and with quite a large team and support of many people, we've been studying this problem, and we've developed an intervention. We gave it a name, Meaghan. It's called Managing Cancer and Living Meaningfully, acronym called CALM, C-A-L-M, and it's how to think proactively with patients, how to help them reflect on their situation, to manage the kind of fears and reflect on the kind of fears Jennifer was talking about, how to make adjustments in their families. You may need a different kind of support from your spouse or your family if you're going through a cancer, how to make treatment decisions, how to think about what's important in your life, how to face the potential of life and to plan for such a thing. And again, to do it proactively. And importantly, to try to help patients manage their fears, process their fears, talk them through, as Jennifer was saying. Now, these are things which a lot of people know a little bit about how to do, but people haven't thought about it in a systematic, organized way. And that's what we put together in this CALM intervention. We got money from the Canadian Institute of Health Research to demonstrate its effectiveness in a large randomized controlled trial, and there was huge international interest that followed. We now have programs in about 20 countries, which include Japan, China, Australia, Jordan, Israel, Germany, Italy, England, just Mexico, United States. We have many places in the United States are involved who are very hungry for this kind of intervention. So we're training people and training them on how to train people in their centers. So we finally put it out in a book. It's being sponsored by Oxford University Press, and if people are interested, we could invite them to the launch, which we hope to have probably at the end of March in this year.
Well, congratulations. That is a major milestone and such an important program. And yes, we look forward to the book launch for sure in March and telling all of our supporters about it. Now, I think we're going to open it up for discussion questions from our community of viewers. So the first one is, often receiving a cancer diagnosis can impact one's decision-making abilities. How do you guide patients so that they are not making rash decisions about managing their cancer going forward? I think I'll pass this one over to you, Dr. Rodin.
Well, firstly, we need to make sure that people have the adequate information. But secondly, we need to give them what we call reflective space. We need a chance for people to think about it, that it's not so easy in a clinic. Time is short in the clinic. And so we're trying to create opportunities outside, in addition to the clinic appointment, to weigh what are the risks of the intervention, what are the benefits of the intervention, my own personal values, and to give them time to reflect and make choices. And I agree that people should not make rash decisions, but they need a place to think about it and reflect. And so that's one of the things we're trying to make also routine in cancer care.
And Jennifer, you spoke earlier about your caregivers, your family being part of this with you. Maybe you could just make comments on how you managed this through your experience.
Well, as I said, we didn't manage it very well at the beginning. It was really tough. We made a lot of really bad decisions, and that was it. We made bad decisions at the beginning because the fear of and the shock of the diagnosis is so huge. So I agree, there needs to be some place to go, some person to call, some group that helps you have time to reflect, because I didn't need to rush into treatment. I really wasn't going to die in the next couple of weeks. I could have just sat and thought about it and picked the proper treatment place for me. I should have got to PMH earlier. You go into a crazyville, and Dr. Rodin's right. There needs to be quieter, reflective time and people that help you through.
I think there's also incredible value of patients hearing from survivors and patients like yourself about their journey and learning from those shared experiences of others. I think you talked earlier a little bit about mentorship a bit. Maybe you could share your thoughts on that.
Well, I would have, once I got into the treatment at PMH, it would have been nice to sort of have someone to talk to that was a little farther along in my particular cancer. So that would happen in the clinic, because each cancer has their own clinic. And it just would have been helpful for me to be able to talk to someone a year in that could say, hey, this is happening, and, don't worry about it. Call me if you're having a problem. I'll help you, figure out meds with you. Because you get really a lot of knowledge by the time you are a year or two into cancer about what's going on. So it would have helped.
Wow, that's really, really great insights. I'm going to go to our next question. Improving the patient experience in the cancer center is great, but what about individual MDs and MDs offices? And Jennifer, you spoke earlier about your cancer journey starting with your MD. So maybe you could talk about your experience there, and then we'll pass it over to Dr. Rodin to talk about his thoughts on connection into primary care.
Well, I was really lucky that my family doctor at that time was my son-in-law, because my original family doctor had refused to give me an MRI because I was breaking my ribs. She said I had osteoporosis, and that was her decision, and I should just suck it up. But I knew that I might have had osteoporosis, but I knew something else was going on. So I coerced my newly married niece's husband to give me some tests. And I said, I like to start at the top. Give me some cancer tests. I don't want to have cancer, but give them to me anyway. And then let's figure out how to attack osteoporosis. So the first test he gave me was the definitive test for multiple myeloma. And even though he laughed and said, "Don't be ridiculous, you don't have cancer, you'll be fine." It ended up being a sort of sad visit to his office when he had to put his hand on my knee and say, like, "I'm really sorry, but you actually do have cancer." But it worked out. It worked out well in the end. But he could have used all these information places to go to, because not every family doctor knows what's going on in the world of cancer,
Yeah.
and nor should we expect them.
Yeah. Dr. Rodin, I'll pass it over to you about your thoughts around connection into primary care.
Well, it's an interesting point about the Cancer Center, because that's such a diffuse term, and I kind of agree with the idea that everything, when we say the Cancer Center, we're talking about everything and everyone. But of course, a lot of the most important conversations and interactions happen in private, small spaces, in a doctor's office, in the community, or in the Cancer Center. And one of the things we've said, Meaghan, is that everyone who's working in the Cancer Center ought to think of it as their job to support the experience of the patient, whether they're a person transporting the patient from here to there, or whether they're a doctor or a nurse. We have to make this part of the delivery of care. That's what we hope Cancer Experience will do, this program will do, is help raise awareness, provide training, and help people understand more fully the experience of the patient and all the things we can do to support it. It has to happen in every single private office. That's absolutely correct.
That's great. So Jennifer, Dr. Rodin, it looks like you're inspiring engagement. The next question: is there a way to discuss suggestions for enhanced patient experience after this session? Who might we contact?
It made me think that going forward, that Cancer Experience ought to be setting up an electronic suggestion box, to think about where we could receive. I think that is one of the things we ought to do. I'd be happy to hear from anyone, Meaghan, anyone who's on today who would like to contact me, or they could, through you, either way, they could contact us. I'd be happy to discuss, to hear about suggestions, or to provide information to anyone who's on the call today.
Great. So if you're watching and you'd like to submit some suggestions, you can either contact Gary directly, and you can get his email address on the Princess Margaret website, or please feel free to contact us at the foundation and we'll connect you with Dr. Rodin. Next one up is burnout. We talked a little bit about burnout among healthcare workers. It's extremely prevalent, especially now in COVID. What more needs to be done to ensure our patients get the best quality of care from those giving it?
Well, I think as we've been saying, I think we need to attend to the well-being of everyone in the Cancer Center. We need to think about how to support the oncologists, the nurses. These people have difficult jobs, treating many people per day in very difficult situations, having difficult conversations. And we want to introduce some of these routine approaches, opportunities for them to reflect on their experience, opportunities for support on an individual basis, on a team-based basis, and all kinds of novel online interventions to support the caregivers. We have to think about well-being as something we have to support for everyone in the Cancer Center. We really are all in it together.
Absolutely, absolutely. Okay, we'll go to our next question. What are some underestimated approaches our medical colleagues should lean more into when providing psychological support in the early stages of a cancer journey?
I would say the single most underestimated approach is empathy. Going back to our discussion earlier, I would say empathy is the least expensive and most effective intervention in cancer care, but we actually don't do nearly enough to treat it. We assume that people know how to be empathic with patients, and I equate it to musical or athletic ability. Some people have more natural ability than other people do, but everyone benefits from training and systematic approach. We need to train people more in empathic understanding, and we have to see that our trainees and our young recruits see this modeled by the senior people learning from. This has to become the standard of care. They know this in Starbucks, that you always, if you go to buy a coffee at Starbucks, you get a very big smile and support. This at the least has to happen as well in the Cancer Center.
Jennifer, there were some pivotal moments, I think, that happened for you where you felt you started to get psychological support. What are one or the two things that happened in your journey that were the most meaningful?
Well, getting in touch with Dr. Rodin and psychosocial was definitely one of them. And knowing that there was actually a whole floor of people that were helping people was like an eye-opener to me. Having the pharmacist come to some of my oncology meetings to talk over drugs, that took about a year before they realized that that would be an asset for me. And that was hugely helpful because the pharmacists, they know everything about the drugs and what's going on. That was truly helpful.
Great.
Yeah, those are two.
That's another wonderful piece of experience that you got to share with other patients on their journey. So thank you for that.
Okay.
Next question up. Jennifer, you talked how it was so important for you to be able to email your oncologist.
Right.
And we have someone here who'd very much like to email their oncologist, but they've been afraid to ask. What's your words of advice?
Well, there seems to be a bit of an issue with doctors and with possibly there's something I don't know about politics, maybe in hospitals where doctors are not allowed to email patients. But obviously that has to change. It's the number one most important way to navigate healthcare is through the ability to email. And I can email Dr. Rodin, I can email my oncologist. My sister was diagnosed 6 months after me with glioblastoma, and her doctors would not allow her to email. And that was like totally a sad kettle of fish for her care. Emailing is really important. Everyone should do it. You should insist. I just think you should insist.
And I'm going to ask the same question to you, Gary. What's your advice here? What's your experience as a clinician?
I agree that we should use things like email and technology to communicate. This is part of the modern age we're living in. But I would add something further, which is we ought to think about communication and information as a team-based approach, that we may not always be able to reach one person, but more and more we're thinking about this. It may be the nurse, it may be the social worker, it may be the doctor, depending on the issue. We need to think about a team-based approach so that it's not just one person, but we have a team that's able to communicate with patients. And going back to this decision-making, sometimes after the patients had a conversation with an oncologist about a treatment, they may want to talk further, for example, with a nurse in the clinic or with someone else about the side effects or other things. But I think thinking about team-based approaches and technology and other means of communication, I would say, are the two most important things.
That's great. That's great. Next up, it seems to me that advocacy for less chemotherapy and going beyond this treatment is becoming more conventional. In what ways is the psychosocial holistic approach more beneficial than chemo?
Well, it shouldn't be an either or. For one thing, we think the psychosocial approach should be part of all cancer care. Chemotherapy is a treatment. It should be used like any other treatment that has side effects. It should be used judiciously so that patients' lives and survival are significantly improved by psychotherapy. We may get better by chemotherapy. We may get better treatments, but it's very important. But we don't want to have more chemotherapy because we can't have a difficult conversation with the patient that maybe further chemotherapy isn't indicated. So I think psychosocial care should be universal. And chemotherapy, like every other treatment, should be weighed in terms of its risks and balances at any stage of the disease.
Okay, thank you for that. We're at our second last question. Dr. Rodin, we got another one that's just come in. Dr. Rodin spoke recently of the need for palliative care to look beyond the cancer care spectrum to improve the patient experience at that stage. Are there examples of best practices from other care spheres already improving the patient experience at earlier stages in the cancer journey?
I think, to be honest, I think there's more work been done in cancer than in other conditions. And that's an interesting phenomenon, why there's so much attention to the experience in cancer compared to heart disease or lung disease or any other medical condition. But I would say, if we look at other diseases, one of the things they've done routinely, better than us, maybe until now, is about making it a standard of care. An example I would give from cardiac care is physical rehabilitation. That if you have a cardiac disease, coronary artery disease, that cancer rehab is part of the standard of care, something that's routinely offered. And we'd like to see psychosocial support, for example, and adequate information, again, be part of the standard of care, not something that happens to someone who specially seeks it out, but something that's offered routinely to everyone in the cancer center. So I would say that making things a standard of care, which also destigmatizes them, I think is one of the things we might have learned from some of the other medical problems.
All right, we have our last question, and I'm going to ask you both to answer this one. Yesterday was Bell Let's Talk Day. So what advice or tips do you have to someone to help manage their mental health during a cancer diagnosis? So Jennifer, I'm going to start with you on this one.
How to best manage from the get-go. That's tricky because from the get-go, it took a long time to figure it out. But empathy, having someone be there so I could have talked to would have been helpful. Yeah. I must say, by the time I got to PMH and got into my hematology clinic and met with my oncologist, luckily he was really empathetic, and it really helped my care from that day forward. So I was lucky to meet up with a doctor and the whole team there. Obviously they're going to empathy school, so they all seem to know how to deal with it, but I was extremely lucky in my care.
I know, Jennifer, you've talked about meditation and other sort of integrative holistic approaches that helped you manage through your mental health during your diagnosis. Could you share some of the ones that were most beneficial to you, others could learn from?
I've listened to, I had some other medical issues when I was younger, and I came across Dr. Bernie Siegel, and I don't know if many people have heard of him, but I listen to his meditations all the time. He's been one of my most helpful meditation doctors. He's a cancer doctor who taught about and learned about the exceptional patient. So he's been a real help. I listen to them all the time, but there are thousands of them out there.
Your mic is off.
Yeah, over to you, Dr. Rodin. Your thoughts on managing mental health through your journey, through a patient's journey?
Well, if I can draw on something someone else said also from one of the symposia, from a lower income country where people were often trying to help in that country. And she said, you can't help me if you don't understand me. And I think that's the first step in trying to help people from a psychological point of view. And it's what they call deep listening. You have to understand the experience of someone. And I think what cancer patients complain about often is gratuitous advice. People who give them advice, don't think about this, don't think about that. Whereas often what people want to do is listen to, be heard, and then we can understand what they need. Some people need help managing serious symptoms of depression or anxiety or even suicidality, and we have approaches to help those people. Other people need reflective space to talk about these things. Some people might need medication. And I guess this is the same principle of all of medicine. We have to understand a problem well in order to be able to help in the most effective way. We do that in medical care, and we need to do that in psychological care in terms of helping the patient experience. We need to listen to patients and respond to what they tell us.
What a lovely summary quote of that. You can't help me if you don't know me. It's very, very powerful. Well, I'm afraid that is all the time we have for questions as we're closing out on the hour. I do want to remind everyone that if you do have feedback or thoughts you want to share with Dr. Rodin as he goes forward to build out this program across Princess Margaret, please do send those ideas in. We also appreciate everyone who submitted or voted on questions for this session. Thank you, Dr. Gary Rodin, for joining us today. It is so clear your passion for helping your patients and the clear passion you have for increasing comfort and confidence in individual person's care.
Thank you, Meaghan.
And Jennifer, thank you so much for sharing your experience with us today. I'm sure your story resonates with many of those watching, and there's many who have learned from your experience. So thank you.
You're welcome. It was nice to do it.
I think we're all feeling more informed and inspired by the promising new patient experience work happening here at the Princess Margaret. Our next session will be on February the 19th and will feature Dr. Gelare Zadeh, the first female chair of neurosurgery at University of Toronto. Dr. Zadeh is shaping the future of this highly technical specialty, not just in terms of clinical practice and research, but in her role modeling as a teacher, mentor, and sponsor of the next generation. You can register for our session at our website at thepmcf.ca/webinars, and I look forward to seeing you there. Until then, we hope you all remain safe and well. Thanks for joining us today.
Thank you so much.